Welcome everybody. We're just waiting for folks to come through the waiting room and we're just going to get started in about 10 seconds. I think we have good quorum. All right, I'm going to go ahead and jump in. So welcome today, everyone. On behalf of the Health Management Academy, we are really pleased to welcome HonorHealth and Ventis for our event today. The real-time health system, how HonorHealth is reducing length of stay and driving systemness with AI and behavioral science. My name is Rebecca Cabas, and I serve as the director on the Member Insights team here at the Academy. So just some quick intro before we hand it over to our presenters today. There's been a lot of talk about systemness in our conversations with leading health systems, in part because of the benefits that they've seen related to their COVID responses, but also because of the improvement opportunities they've identified that promise to provide even greater value beyond the pandemic. We know that workflow and care process inefficiencies mean more work for our care team members, which can lead to burnout, poor care quality, and lower patient satisfaction, not to mention lost revenue. So this is where integrated process and analytics, both are key attributes of systemness, come into play. But it can be difficult to identify the operational steps that will ultimately translate into the desired outcome. And even if you have unlocked those operational changes necessary, it can be difficult to hardwire them. So in today's conversation, we'll hear how HonorHealth, in partnership with Ventis, is making progress towards their systemness goals, even in the context of the many challenges presented by the pandemic. They're using real-time data and artificial intelligence to standardize operations across the enterprise and to enable quicker, data-driven decisions that help clinicians improve patient flow and their overall experience. So I want to take a moment to introduce you to our speakers today before I hand it off. First, we have Kim Post. Dr. Kimberly Post has been with HonorHealth in Scottsdale, Arizona since 1991. She served for 2.5 years as the Executive Vice President and Chief Operations Officer, where she leads the overall hospital division to achieve operational and clinical excellence. In her long tenure with HonorHealth, she served in many roles, including staff nurse, service line leader, CNO, and operational vice president. Her ultimate professional goal is in her current leadership role, where she is charged with defining strategy and improving operations and the clinical environment to better serve our community. Dr. Post has her bachelor's in nursing, master's in business administration, and a fellowship at Wharton School of Business, as well as her doctoral degree in nursing practice from Case Western Reserve University. So not busy at all. And we have Ashley Gerhardt. Ashley Gerhardt has served 18 years of experience in healthcare with a background in inpatient and ED trauma nursing and an ACS level 1 trauma facility. Her passion for innovation and operations in healthcare is driven by a desire to improve the patient experience and outcomes. Ashley joined HonorHealth in 2016. During her tenure, has led the organization in developing a comprehensive network resource staffing pool of 600 employees, capacity management, including centralized patient placement, and operational and reporting enhancements in payroll and the scheduling platform. Prior to joining HonorHealth, Ashley served as Dignity Health Arizona Service Area's internal consultant for performance excellence. Ashley is currently enrolled in her doctorate of healthcare administration. And we have Michael Muka. Michael is the Vice President of Customer Operations at Ventis. He has over 20 years of experience in technology, operations, and consulting. And prior to joining Ventis in 2016, Michael served as an executive role in sales, marketing, and customer success at Evolent Health, MD Byline, the advisory board company, and other software-enabled service providers. A quick overview of our agenda today. Welcome all of our presenters to the Zoom stage, first of all. For today, here's our overview of what we have lined up. So first, we'll start off by hearing from Kim, Ashley, and Michael to really frame the industry challenge and opportunities around healthcare operations. Then we'll turn it over to Kim and Ashley to tell us a little bit more about HonorHealth's journey to becoming a real-time health system. We'll segue to the bulk of our session, which will be in the fireside chat format, and Michael will help moderate a chat with Kim and Ashley and explore some deeper themes, how they're driving systemness and reducing length of stay with AI and behavioral science. And then, of course, we want to make sure we have some time at the end for Q&A. As with other virtual presentations. Want to make sure that you feel free to submit your questions throughout in the chat function, and we will be monitoring that, holding most of the questions till the Q&A at the end. But if you do have any timely questions, please feel free to submit them through the chat. And I would also say, please take a look at the chat as we share some resources, supplemental resources along the way. So without further ado, I'm going to pass it to Kim to start us off for today.
Thanks, Rebecca. So I proudly sit here today, safe from COVID, and my husband said, "Hey, can you get through your entire presentation without saying COVID? Like, if you say it, maybe you should have to pay a fine." So I want to talk a little bit. It's going to pop up, but really, this is a tactic that we deployed before we actually started to experience this lovely last year. So I'll talk to you a little bit about HonorHealth. And as Rebecca noted, I've been here for 30 years. It's a great place to live. Lots of people are visiting right now, even though we are kind of in the middle of a pandemic. People are feeling safe. It's been very crowded here because the weather is extremely wonderful, as you will probably know if you've been out here. So we are a not-for-profit health system. We're the product of two not-for-profit community health systems that merged in about 2014, Scottsdale Healthcare and John C. Lincoln Health Network. So we're still not for profit. We just opened our 6th acute care hospital in September, believe it or not, in the middle of all this fun. We opened a hospital. We have dozens of primary care clinics. You'll see those outlined on this great map. And then a cancer care network. We have a pretty robust research institute and other community service that have been anchored since these hospitals began. One of note is a large food bank that has been here for over 90 years, I believe. I'll also mention that we have an ACO, and it is embedded within our clinically integrated network called Innovation Care Partners. That is a partnership with about 2,000 aligned physicians in our network who then again manage that ACO and our risk-based contracts. Across the system, we have about $2 billion in revenue per year, and our mission is to improve the health and well-being of those we serve. We have great values that we're going to talk a little bit throughout this. I'll just note them now, and hopefully you'll hear them resonate within our presentation. Innovation is one of them. We changed our values about 1.5 years ago, and I've never worked at a time in my career where people really embrace the values more than they do today, because I think they just resonate with who they are. 2 that are a little bit different. Innovation is 1. Collaboration, accountability, respect, and empathy. Empathy is a little different than what a lot of care stands for across health systems across the U.S. And we pride ourselves on empathy and listening to not only our patients and families better, but also each other so that we can have better products. 5 of our 6 hospitals are magnet. The 6th hospital is not eligible, so we're the only health system here that has all of our sites magnet recognized. And really in the first years after our merger, we really began to integrate, trying to become, a system of care that allows us to react and respond in a way that really puts us above the other competition. And I'll speak to that a little bit later. It's important for us not to be siloed. We've went through a plan around service line distribution, so we aren't siloed. You'll notice on this little map that none of our hospitals are really further than 9 miles apart. So we really do have a lot of opportunity to leverage ourselves and not offer 100% of everything at every hospital. So we have decided to sort of create identities for each site. And those identities really help us drive care to that particular site and then be able to function, I'd say, with the right resources for the right patient at the right time. Next slide. So I'll talk a little bit about sort of that current state and why we decided to take this journey. We knew that there were a lot of inefficiencies, and there was a lot, we were very not system-like. We were still east side, west side during the merger, doing things kind of completely different. And I would say that we had no ability to predict, predict surges or demand. not alone move a patient around to a different site to get more specialty care. It was really hard to gain visibility of where we could do it, or when people were, playing lip service to, yes, Systemness, but then when they went back to their site, they did whatever they wanted to do. We had some sites that were packed, even overflowing, and some that had a lot of capacity. And then there was no way to really facilitate, I'd say, streamlined transfers to the right place, even from the ED. So there was a lot of variability. We had 2 transfer centers. We had, all kinds of things that we needed to bring to one. And in the middle of that, really, the culture of still being 2 different organizations and functioning in 2 different ways. So that's when we went through the process, and I highly recommend it if you can. It's a service line distribution plan that's really, like I said before, the right care for the right patient at the right time, and then really providing resources so that you can do the right thing at certain hospitals. Each one of our hospitals has sort of a key identity, and then there are certain things that there are sort of baseline services there, either up to comprehensive, right? And each site kind of has that defined list, I'll call it. And then that allows us to move patients and resources to the right, the patient to the right resources and the right care. And then it also allows us, I would say, for things such as open heart, things like that, that are very difficult to resource, we can really concentrate that at 1 or 2 sites, and then easily move patients, especially with this, with Cuventus, actually even before we start any care. So it's been, I think, a really good addition to what we're trying to drive here with this platform. So Ashley, I'll turn it over to you.
Yeah, thank you, Kim. So as Kim mentioned, as a result, we weren't optimally utilizing our assets. So for example, we sometimes rejected transfers or delayed them because of poor bed visibility. Our performance was difficult to measure, and decisions were hard to make in real time. Our staff lacked the resources that they needed to properly care for our patients, which then further attributed to burnout. And then all of these delays in care progression detracted from the overall patient experience. Next slide. So as a leadership team, in order to achieve true systemness, we embarked on a strategy focused on 3 key objectives. First, we needed to improve patient flow and throughput in order to smooth the care process and create better outcomes for our patients. As a part of this, we needed to reduce the complexity of the discharge process. And we're not alone in this. This is a national issue across the healthcare operations today. And finally, as a core part of this, we needed to help our frontline teams. We needed to focus on innovations that would give them back the gift of time and reduce the complexity that they encounter each day. As we looked at addressing these challenges, we believe that there was a new opportunity to leverage artificial intelligence and machine learning. We also knew that we need to incorporate principles of behavioral science to truly drive the change that we needed to see within our organization. And we needed to apply lessons from operations management as part of this strategy. So we started exploring various approaches to achieving real-time operations and turned to Cuventus as a strategic partner to build these capabilities. Michael, I'll now pass it to you.
Great, and thank you so much for that introduction, Kim and Ashley. Cuventus was built for health systems to address the challenges that you both just described, helping to achieve the vision of operational transformation that health systems nationally are increasingly driving towards. We provide real-time, we're the first real-time operations system for healthcare, taking modern innovations in artificial intelligence and behavioral science. And we couple it with deep expertise in clinical operations, performance improvement, and change management. We're a proven partner with over 120 deployments. And we've been thrilled and honored to work across the continuum of care settings, from community hospitals to large urban academic medical centers through to large and mid-sized health systems similar to Honor. Based on our experience, I'd suggest the challenges that Kim and Ashley outlined are pretty common and shared by many of the health systems on the webinar today. So what's holding us back? Well, a good place to start, and Ashley, you highlighted this, is discharge planning. Most health systems have tried to reduce length of stay using a combination of performance improvement projects and their EMR with limited sustained success. And to support that assertion, the data shows that length of stay has been flat nationally for 15 plus years, despite reducing it consistently being a top operational priority for health system leaders. Why is that? Well, first, teams are inundated with data, making decision-making really difficult counterintuitively. The care teams need to manually navigate through each patient record, manually project and enter estimated discharge dates and dispositions, sort through open orders and try to figure out which ones could be barriers to that patient's discharge or placement. And they need to do this in the 30 seconds they have per patient during rounds. It's no wonder they're not able to do it consistently. What's more, the processes really are ad hoc and vary floor to floor, care setting to care setting, department to department, facility to facility. More often than not, care progression processes aren't discharge focused, and everything's pretty manual. One of our partners at one point in time identified 279 manual steps it took them to discharge their patients. EMRs simply weren't designed for managing operational decisions and workflows. And fixing this is hard, not only because of the limitations around what we're trying to accomplish and the capabilities of our native EMRs, but also because of the IT and project management resources or that capacity across all the health systems we talk to nationally. And this kind of sustained change management at the scale required is really difficult. So now let's compare that to where we'd like to be, managing operations in real time, making it easier for frontline teams to do the right thing every time, and that looks very different than what we described on the left. You have artificial intelligence and machine learning that sorts through millions of data points and provides intelligence, predicting estimated discharge dates, dispositions, barriers, and then automating the key steps to reduce the burden on the care teams by augmenting the decisions, while also putting those key decisions that reduce length of stay at the front of the list, making them happen earlier in the patient stay, but certainly doing that never at the expense of quality and/or patient outcomes. The best practice processes proven to reduce length of stay are hardwired into workflows, using the behavioral science that we've alluded to, principles to create habits and reduce that variability that causes such challenges around how we manage these processes. And with this approach, discharge planning really can start at the point of admission. And you have a strategic partner that's aligned with you to drive outcomes, a partner that brings a proven set of best practice processes, deploys the technology, helps drive the change management, and then helps hardwire continuous improvement. For this to happen, though, you need to take a systematic approach, combining platform, process, and people. And so for anyone who's not familiar, Venice is a real-time operations system that encompasses each of these three critical components. First is an automation platform. This integrates with the EMR and enables our partners to manage operations in real time, allowing them to create a closed-loop system, using that AI and ML to identify operational issues, the bottlenecks in patient flow, whether those bottlenecks are historical patterns, whether they're happening right now, or whether they're happening in the future, in which instance we need to help predict them before they occur. But that's not enough. You also need to bring help to the frontline teams to understand how to address and avoid these issues, which we do by orchestrating actions and using behavioral science techniques that allow you to form habits within the organization that last. Finally, you need to understand whether you're effective, whether you're identifying the right issues, and whether your teams are taking the right actions. So we close the loop with technology for managing accountability. And this platform really is the core of the system. But on top of that, we've developed solutions. These are best practice bundles of software with proven operational processes and management practices. And we provide these complete solutions to address operational challenges across the acute spectrum, from the inpatient side, the ED side of the house, perioperative, and increasingly system operations or command center settings. And then last, but certainly not least, we work with our partners to establish governance, drive change management, and operationalize the software. Our team includes clinicians, project managers, and technical specialists who partner closely with our partners to use a proven methodology to make sure that we're able to consistently deliver results. Most importantly, with the system, we're helping our partners to achieve transformative results. At the end of the day, we also have businesses to run, and we need to be able to validate that the work that we're doing is actually increasing our ability to extend our services to those communities who need it the most. And we're really proud to say that we've been able to eliminate thousands of excess days per facility, decreasing length of stay by 0.3 to 0.8 days, and driving a 50 to 90 basis point increase in cash flow margin, which generally contributes to about, depending upon the size of our partner hospitals, $10 million in annual value created. But it's not just the metrics. As Kim and Ashley spoke about, we have to also help our partners drive Systemness, increase the value of the EMR investment that's so critical to their ongoing day-to-day care delivery. And we also need to be able to do that in a way that improves quality as well as the patient experience. And in many ways, most importantly, we have to be able to enhance the lives of our frontline teams, particularly coming out of the situation that our caregivers have experienced during this pandemic. We're not going to be successful if we're not able to allow them to simplify their work, reduce the cognitive burden, and let them focus on the things that matter most in their day-to-day patient care. So now I'll turn it back to Kim and Ashley to take us through the HonorHealth transformation and their real-time experience with Cuventus, as well as the work they're doing in parallel.
Thanks, Michael. Let me just start by giving you a little bit of information about our journey and how we're at where we're at, and how we're really transforming into a health system that operates in real time. And so, like many people have said, we started this journey prior to COVID, and we knew we had issues, but it was just highlighted even more during our COVID surge, actually the 2 COVID surges that we've had. The importance of really leveraging as a system and getting the right patient to the right place has never been so ingrained in us as it is now. We surged twice, once right below probably 400 patients with 5 hospitals. And this last one, right around Christmas, right before Christmas, we surged to 500 COVID patients. What that really taught us was there is so much opportunity in leveraging each organization for patient placement to allow us to function during this pandemic. We never transferred one patient out. Actually, we transferred 2 out for lung transplants. We never transferred any patient that entered our system with COVID for any reason. We moved them around to get access to ECMO or other high-end resources, but we were probably one of the only systems in the state that was able to care for every single patient that entered into their system. And it was kind of manual, really, when you think about it, because not all our hospitals are up, and mission control is not up with Cuventus. So it's now more important to us than any time in our past. As I mentioned earlier, we were 2 health systems that merged. We had 2 different EMRs. So the first thing we did was a little thing called Epic, right? Epic is, people used to think it stood for something. It was an acronym. It's not. Epic is Epic, right? And so anything you do with the EMR is Epic. We updated Epic in our 2 Phoenix hospitals at the same time that we implemented the transition in the Scottsdale hospitals. And so it was a heavy lift, and there was a lot of work to do. I learned about Cuventus right after I started. We had just actually implemented Epic, and I'm like, we're not quite ready, and we really need to get some communication devices and some other things updated. So really, that's part of your work to do on whether you'd be ready to do something like this and have the technology to support. So in the next phase of our journey, we looked at the inpatient solution and the ED solution, and we actually implemented those. We're on the 3rd hospital now, and together we're looking at peri-op, and also we manage our outpatient or our outside transfers. We just transitioned our transfer center back into our from an outsourced company. In parallel with that, we're launching all of these things in our ED departments, and in I'd say our biggest focus starts in the ED and in the outpatient or in the inpatient area, but we're intensely focused to improve each time we bring a hospital on board, moving towards getting all 6 in the next year. So we took a side-by-side approach. There's a little bit of overlap. We started with our most difficult hospital, and they've been champions and have really developed the process that we've been standardizing on the rollout. So after we did the rollout, I don't think it was hardwired, and it was not part of their culture yet when COVID hit. So I would never implement during a pandemic. That'd be my first advice. But if you have to, you really need to have the resources to help people see this as a way to manage the issues and not just another thing to do. And we weren't quite there yet. So we had to circle back after the first surge and sort of reiterate and solidly support the team there. And I think they're doing really, it was time and money well spent. The next phase that we're going to do is unlocking these efficiency across the system. The last 3 hospitals will come up, and then we will work at a network operations center. And that will help us manage that continued flow using AI and machine learning across the network, and then really optimizing the capacity and the strengths of each hospital that is defined in the service line distribution plan. So next, I'll have Ashley tell you more about the work that's optimizing the patient flow.
Yeah, thank you. So I want to highlight the inpatient solutions that we've rolled out, which look familiar since Michael highlighted them earlier. So across our sites, we've rolled out the discharge planning, which hardwires discharge planning practices for our frontline care teams and uses AI and machine learning predictions to predict estimated discharges, discharge dates and dispositions. And then our barrier management, which uses machine learning to help proactively identify barriers for complex discharges, and then orchestrates the coordination amongst the ancillary teams to resolve those barriers. And then performance improvement automation, which gives our leadership team visibility into how our teams are doing compared to best practices, so that our managers know where to focus their improvement efforts and offer kudos to their teams where and when needed. Together, solutions help us identify and resolve discharge barriers upstream. The system allows us to establish processes and data foundations for our multidisciplinary rounds that we have on each unit. And then early management of discharge barriers and mechanisms are identified to hold care teams accountable to the prescribed processes that we've implemented. In a moment, I'll tell you a little bit about how at a system level we'll use this with our network operations command center to leverage the information across all facilities. Next slide. So as Kim spoke about earlier, this is our Deer Valley site, of which is most mature in the Qventus process. So with the inpatient solutions in place, we wanted to show you the impact of the best practices on excess days, which you can see here represented in the data. On the left, you can see that we had 1.67 excess days per patient when there weren't early discharge planning, meaning the EDD or disposition was not set prior to the second midnight. But when our team did identify the EDD and early discharge planning before that second midnight, we were able to reduce about over a half a day, or 33% of excess days. Of note, as Kim mentioned, this was through COVID, which was our busiest time, and a lot of moving parts during that time. As we continue to do this over time, we'll have a larger data pool, and the data continues to reflect the effectiveness of the best practices that we've implemented across our system. In addition to this quantitative impact, it's also helping our teams by pulling forward the discharge planning process on all levels, which means less phone calls, less chasing down orders, and less chaos on the day of discharge for our patients and our staff. Next slide. So now we have the Inpatient Foundation in place to identify and resolve the discharge barriers upstream. We have standardized processes and data foundations for discharge planning and rounds, and early management of discharge barriers and mechanisms to hold our teams accountable to the prescribed processes that we've implemented. This Inpatient Foundation gives us the processes and data to enable our system-wide network operations center in a few different ways. So first, we have the inpatient data that will give us visibility into expected bed availability across the system at all locations. We'll be able to see top discharge barriers and then shift resources accordingly ahead of the problems. And finally, the information will help us automate escalations to our system team, which then can provide support in the discharge process. Let me tell you about our vision for our network operations system as we move forward. So at the system level, the command center leverages information across the facilities to gain advanced visibility into bed availabilities. It identifies top barriers across the system to allocate resources accordingly, and looks at discharge barriers to manage escalations when units are overloaded with capacity. It comprises of 3 different pillars here. So capacity intelligence will help us focus on predicting and managing bottlenecks and surges before they occur. This machine learning model can predict up to 4 hours or 7 days in advance to provide visibility to incoming demand. Our care progression optimization will help us streamline discharge and step down AI-driven orchestration. We'll be able to hardwire these processes for proactive morning discharge planning and for managing discharge delays. For example, we can utilize the nudges that prompt patient flow to our coordinators and to our charge nurses on the unit to help remove those barriers to discharge. And then the intra-system transfer will help us load balance the patients across the system, as Kim mentioned, to meet the needs of those service lines and where we can better place those patients and predict opportunities within our system. We're really excited about implementing this product across not only our facilities, but as a network command center to drive systemness. Next slide.
Thanks, Ashley. So through all this work, we're really excited that we're here today and that where we're headed as a system. These are tools that have never been offered to us before to maximize and improve the care experience. First, we're moving towards much greater standardization for this discharge planning and care progression across all our facilities, as Ashley outlined. We feel much more confident in our ability to consistently deliver the highest experience and quality for our patients now that we're moving in this direction. Next, it's also reducing the complexity of the work environment for the frontline teams. And in my past, I've been a supervisor. It was one of the hardest jobs I ever had as a nurse. And the complexity of what needs to happen when the tide is rising and you've got to find a way to sort of mitigate. You have a tool belt full of about 20 things that you can try. If you can really know that the first two are the two that are going to make the biggest difference, because it takes into account everything that's happening in your ecosystem between the ED, the floor, planned discharges, even the clinical care of the patients that are either on their way out or on their way in. If you had all that and you knew you could make a better decision from the front line, it's powerful. It's a very powerful thing. Lastly, the strategy also helps us strengthen our system financially. So decreasing our LWATs, managing the throughput, not having to build beds or create beds for overflow because you're utilizing your beds in a much more streamlined fashion. I think that's critical. Lastly, next slide, please. Is really lessons learned. And I do mean that. If you have a chance not to do it during a pandemic, that's what I would highly recommend. However, it did teach us some things, and it really made this move, I think, much more powerful, and this investment in our throughput much more powerful. So as we reflect on those and that journey, here are a few things that I want to share with you. First, there's undoubtedly a significant opportunity to improve patient flow everywhere. There's no perfect place for that. There's always a better way to do it. And as in many things, when we went through COVID, we knew we had problems, but it just shined a light on it even more. And as we start to really think about what it's going to be like moving forward with COVID or any other virus that could be a part of a pandemic, we need to really understand how to do that safely. And so understanding where patients can go safely, COVID units, cohorting, whatever it is you're trying to accomplish, this is the information that will help us get there. Second, driving this level and the scale of transformation takes a lot of discipline. It requires us holding all these teams accountable. You can get nudged until the cows come home, but if you don't follow a nudge, it isn't going to do anything for you. So we have to create a system where they believe what the nudge is representing, and that the staff feel empowered to do what the system is actually encouraging them to do. So we track all that, and we have an accountability model, and I think Ashley will talk a little bit more later about the governance on that. We have the right data at the right time to help the leaders really make better decisions and to actually auto-correct things that are either going to happen or in real time happening. Throughout this process, it's important to reinforce this culture of innovation. We don't use artificial intelligence in operations like we should. It's a new tool in our toolkit, and we have to help people understand what it means. It doesn't Qventus doesn't fix the problems. We fix the problems with Qventus, right? So we can't just say it works or it doesn't work based on one thing. It's really us together that really figure this out. So it's really about introducing innovation, helping people really embrace it, not be afraid of it, but help us utilize it and make it a worthwhile tool. We continue to remind and educate our teams that we're making these new tools available to them to make their jobs easier, to really meet the needs of the patient. And again, really optimize, I would say, our operational environment to do the best thing for patients. So that concludes our presentation. So I'll turn it back over to Michael for the fireside chat.
Great, and thank you, Kim and Ashley. That was really just a fantastic overview. As we think about going forward, and we talk a little bit more in detail about some of the things that folks on the who are attending the webinar may be interested in, I would encourage folks who have any questions to put them into the chat at any time, and we'll also do our best to leave some open time at the end for a Q&A session. So to start, since one of the major themes of the session is around systemness, I'd love to double click on that a little bit. As you guys talk through, and you highlighted a little bit of this as both of you were going through your individual sections, why was improving patient flow critical for driving systemness as you thought about that at a big picture level? And how does it create a strategic advantage for HonorHealth in the Phoenix market?
Well, I think, Michael, before, when you look at our system, we are very close in geography, right? We don't have a large drive for patients or families, or even a transport for 9 miles. So we really thought we had a better opportunity to offer more, offering less at each of the hospitals, but leveraging that. So I think that really using that to maximize the assets and the resources really improves quality of care to the community, especially in the high end stuff, right? Things that require not only, maybe you have 2 physicians that do it. It's comprehensive stroke, or sort of some intervention that has to do with stroke patients that we only offer in 2 places in Phoenix, or open heart or TAVR, you name it. These things don't have 75 docs waiting in line to do it. We have a very finite number of resources of physicians, but also the staff that really support the care. So it creates this advantage for us to really optimize what we're offering and consolidate some volume and some key programs so that we can manage that higher acuity in a way that is competitive. Some of the, if any of you have a transfer center, there are some patients that people sort of take their time in saying, yes, I'll take that one. And then there's some that people are like, no, I'll take that one right away. So we need to be first to say, we've got the resources, and we're ready to go. And we are absolutely available to take that patient and meet the needs of the state or region, not only our own market. So I think that's really key. Now that we have 6, we really did manage patients pretty well. We want to continue with that theme as it relates to how we distribute service line care. So we want to be able to see the bigger picture. And then also, I think really the predictability of what we can do with the information and predict surges or opportunities. I think the more of that we do, and we are not just responding or reacting to a need, the better it is for everybody. So the other piece of it is really addressing leakage. So it's, by shining a light on all of this and really having a centralized operations center, it really makes it all very transparent. So we monitor every patient that goes out of the system. If we were able to do that care, what we could have done to keep them. If it was a delay or a resource of a physician or whatever, we're constantly looking at that and able to address it. And this information just really helps us, I think, function much better, and it helps us compete in probably one of the hottest markets in the country. So this also, I believe, is kind of complex for the staff, right? The staff have to really understand what this offers them, and have to understand the innovation, and we have to create an environment where we support the staff to understand that. So I think that's another commitment that we make, and I really having gone through this disaster of this pandemic, lots of people have pointed out how well we operate as a system, and it can only get better from here.
Yeah. Absolutely, and you know, as someone who has had the privilege and honor of working with your teams for the last few years, it's really been impressive to watch. As you thought about it from a financial perspective, what were the things that were the highest considerations around the opportunity to improve patient flow, and why patient flow amongst the other things that you might have selected that could elevate the financial performance of the system?
Well, I think eliminating excess days creates capacity. We picked the Deer Valley is our most complicated site. We picked that. And some days, it was a good decision, and some days it makes it harder, but they have really embraced it. And that hospital runs at probably 90 to 95% capacity most all the time. They sit in it's sort of an intersection of our valley that is extremely busy, one of the busiest zip codes as it relates to growth in the nation. So we started there because we were losing so many patients out of the ED, but also we were not able to keep the throughput going to keep patients moving to create capacity for what was just even entering our EDs. And so really that excess days is really the focus on that. And I think it strengthens margins because we were able to accommodate more volume. I will say that's the toughest site because it is always so full as it relates to turnover, and staff satisfaction is pretty good, but the turnover is challenging because it's always crammed full. So we were able to sort of decrease a little bit of the complexity, give them a different tool to use. And I think that the staff is appreciative of really shining the light on barriers to keeping patients moving on the inpatient side. Now, we do have, with the ED implemented, we are down in volume, but the problem is that all the easy patients left. And I think across the country, I'm hearing people still saying ED volumes are down. Our ED volume is down, but we still have a lot of challenges in throughput because the patients are so sick. And so we don't have all the easy ones, not all of them, but the grand majority of volume lost has been these really lower acuity patients that sort of diluted what we were trying to care for. Now we're left with people who are really delaying care because they don't necessarily want to come into the emergency department. So they're much more acutely ill. And then, just the sicker ones. And so the throughput on that and the challenges around that, I think are going to get us all right. That's where we need to really do some work. With Cuventus, we've been able to look at different parts of pieces of where we need to rearrange or reactivate the team in a different schedule or in a different way. We're getting ready to embark on really even looking at the whole model of care as it relates to sort of our new world order in this high acuity in our EDs. And I think Cuventus is going to be able to give us the data and sort of that minutia that we need to be able to do that.
Great, thank you, Kim. And actually, maybe I know you both have a background in a very high attention to frontline burnout from your both of your work as nurses. So actually, maybe in the work particularly around the ED as well as the inpatients that you oversee, you talk a little bit about the frontline burnout issue. It's certainly something that has been lingering for a long time, and the last 12 months have certainly not helped. As you think about the challenges around burnout at the facilities, as well as which strategies you've been deploying and where you see Cuventus fitting into that.
Yeah, Michael, you're right. So we have experienced some retention and recruitment concerns, a little bit prior to COVID, but definitely heightened during COVID. And so, with Cuventus, we wanted to make sure that we pulled in those frontline staff to help them really identify their preferred workflow to ease their way and work at the top of their license. And so we've been able to do that. One example is, using the Pathfinder tool up on the nursing units as a handoff tool. That was not a recommendation of us or Cuventus. It was something that those charge nurses really adopted to ease their way from shift to shift and handing off report. And so, just keeping those employees engaged really helps with the retention of our staff, and they've really linked up to the Cuventus tool.
Yeah, great. I know we've talked a lot about, and again, having had the privilege of working with you all for the last 2 years, I know how much you value the need around change management and embracing and kind of bringing all the stakeholders together and make sure that we're doing this as a team and not doing this to our frontline workers. So as you guys think about that, the import of that and the behavioral science side of how we work to drive and sustain the transformation that's underway, how did you guys think about this throughout the deployment, acknowledging also, Kim, as you've referenced a number of times, despite your husband's encouraging of you not, the challenges we've experienced with COVID. And what was your experience in working with Cuventus as your partner in this? And then how do you start thinking about what that looks like going forward around sustaining the changes that have been made from an accountability perspective?
Well, I think one of the appealing things about this model, when I first this product software that I heard about, was there was an accountability model embedded in it, and I always use when I went to get my doctorate, I remember the first project I proposed to my chair, and she's like, well, how do you know they're doing it? And I'm like, what do you mean, how do you know they're doing it? Like, I tell them to do it and they're going to do it. We're going to educate them and they're going to do it. And she's like, but how do you know they're doing it? Right. So really any good part of a process improvement, any change management, anything you do, you really do need to embed an accountability model in it. Well, this is what the beauty is, right? There is accountability and transparency in the product, right? It helps us, we know when there's a nudge for people, first you have a problem, right? You create a nudge for people to do the right thing. And then you can see when they got the nudge, if they ignored the nudge, you even know who did it. And you can go back and you can coach and you can mentor and you can help them understand that we're not kidding, right? It's a nudge to help you do the right thing for patients. So I think the accountability model is really embedded in this whole process. And it really appealed to me because in healthcare, how many times have you implemented something and you think you're done when you train the last person? And then everybody's, gets religion and wow, yay, all big uptick. And then as soon as you're not paying attention anymore, it goes right back down. And so this really was a way to sort of incorporate accountability into the plan. And I think that's key. I think you have to teach people how to use it in the right way and coach and mentor and make that part of your culture. But I think that is definitely one of the things that I find probably one of the best things about the product. You can use it for several things, right? There are certain things that are sort of, I won't say can, but are part of the initial rollout. But there are lots of problems now people are trying to solve using it, which is grand, right? That means that they're adopting the innovation, they trust it, and they think it's going to be able to be helpful in other care settings or care problems. So that part's really, really good. I think the other piece, talking about sort of the journey, is we have a chief transformation officer, and all of our IT and marketing and really innovation really comes up through him. He's a physician, very dynamic leader. And he has been very key in helping us vet out, this is the product that we need. This is the way we need to use it. And it is very much a partnership from the very beginning that he has been very supportive of, and strategically is looking at it as a core part of what we're doing for transformation. And so I think that's another key thing. I would say getting your IT leader or transformation leader on board to what this offers for operations is key. And then I would say during the pandemic, I would always get somebody reaching out to me offering from Cuventus, is there anything, how are you, first off? How is your search going? Is there anything that we can do for you, right? We're working on a few tools that might be helpful to you. We'd get on a phone call, you show us how that works. From supply chain management to many other things, to ramping up OR, right? To coming out of a surge. And so I think that the team is much more focused on creating a partnership long-term with our organization to optimize what they're bringing to the table with us. And so sometimes that isn't necessarily what you get, especially with, innovation. Some people drop and go. Some people, everything that you need help with after the initial implementation costs you more, things like that. It's really a partnership, and during COVID, even a deeper partnership on, we think we can solve some other problems for you that might help you sort of weather the storm. And I will say, just really getting to know the team, and if things aren't going as we suspect or it should go, just reaching out and being able to share what the issues are, and the response has been phenomenal. And so I really would put this in my career, one of the top relationships that we have. I say vendor, but it's a little bit deeper than that. So I do think that it's a partnership to really drive change, and this tool is going to be able to evolve over time and include other parts of our organization. And I have a lot of confidence that we'll be able to do that together.
Great. Thank you, Kim, and thank you for the kind words. And before we move to Q&A, I see some questions starting to come in. Ashley, you're the one who has been the executive over the day-to-day work that you've done with Qventus. Anything you'd add to Kim's characterization? We know, and we talk a lot about, this is hard, right? If solving these problems were easy, and if it didn't involve thousands of employees with different perspectives, different roles, different settings, we would have solved these problems a long time ago. But I'd love to hear your take of kind of what it's been like, and any recommendations you'd have for folks who might be considering working with Qventus in the future.
Yeah, so I echo Kim's comments. It's been a great relationship. Going back to what I mentioned earlier, as far as pulling in the frontline staff, they've had some amazing ideas that have not been implemented in any other healthcare organizations. So for instance, anytime that we identify a discharge, sending a nudge to security to go ahead and get those belongings up to the room, or if they have medications down in pharmacy, getting those patients' medications up to the room to further, to help move that discharge process along. And those are all frontline staff ideas. And that really drives engagement. Going back to really our accountability model, we had the opportunity to create a hospital throughput committee at each one of our systems that then floats up to the network level and an executive steering committee, so that we can really see the opportunities or trends across the network and really capitalize on those. And it's been really great.
Great. Well, thank you both so much, Rebecca. Sorry we ran a little bit longer than we had planned, but hopefully everyone appreciates the perspective. I know that I do. So maybe I'll hand it back to you, Rebecca, to either open us up for questions or bring us home.
Yeah, not a problem, Michael. And thank you again for everyone's contribution so far. And we do have a number of questions coming through here to the chat. Some a little bit more tactical, a little bit more, others some more strategic. So do my best here to triage them to you, Michael. We have a question. Do you discuss discharge status for every patient every day on each inpatient unit? If so, who's present for that discussion and what time of day?
Yeah, I'll take that one, Michael. So we do these during our multidisciplinary rounds, and we have charge nurses, case management, therapy, and then the frontline staff who are reporting out on their patient assignment each day, looking at what needs to happen for that patient in order to move that discharge process along. And that really feeds off of that EDD and disposition that I had referenced earlier.
Most of those are happening in the morning, like around, not all at 10 o'clock, but around that time.
And another question, I think for perhaps, well, I don't know who'll take this, Michael, maybe you start. Could you characterize what types of elements in the AI looks at within the Epic records?
Yeah, we can get into the real details there, and happy to kind of connect offline on that. But essentially, if you think about the inpatient work, I'll focus on that because we've talked a lot about discharge planning. What we're looking at is what is happening within that patient's, what are they being admitted for? What are the order sets that are being processed associated with the progression and the kind of the velocity of a patient's care? We couple that then with all kinds of elements looking at payer class, gender, age, in some instances, able to, depending upon the richness of the data we're getting, look into social determinants of health and other things. We pull that all together and then compare it against the historical records of patients from that hospital and that health system. We don't look at data outside of each of our partners' environments, and to do that, we bring in anywhere from 6 months to ideally closer to 2 years of historical patient records, so that we have a really rich understanding of historically patients who have looked like this, what has been their care progression, how long have they been in the hospital, where have they gone to when they left the hospital.
I'd like to add to that, Michael. So for the ED perspective, we're looking at turnaround times for labs and radiology and all of those things. So they're pulling those straight out of Epic, the order time, and then the result time, and looking at that, and we're tracking and trending those results.
Great. So we have time for just one more question. Michael, this one's for you. Can you just talk about any other clients you work with that have significant distances between hospitals inside a specific region?
Sure. We have a partnership with Common Spirit, the legacy side of Dignity Health, where the hospitals we work with are in multiple states, and where most of them are centered in California, from anywhere from Northern California to Southern California. One of our oldest partners and most long and deep relationships we have is with a health system called Mercy, formerly Sisters of Mercy, based in St. Louis, and their network of 40+ hospitals spans multiple states. They have some markets where they've got multiple facilities, but generally those hospitals are hundreds of miles apart.
Apologize, we didn't have time to answer all the questions today, but you will be able to connect with these folks in follow-up if needed. So please look out for that email coming from our team at the Academy, and we can absolutely help you get in touch. Ryan, I do believe we have a couple of closing slides we want to just turn to in our last minute here. Quickly, before we wrap, I do want to just share that we're going to be making available this research report on discharge planning and best practices. So if you want to learn more about, or hear more, read more about the stories that were shared today, it really uncovers and quantifies some best practices for reducing excess days by analyzing 75,000 patient visits across different hospitals, different sizes, clinical models, and so forth. And so we'll be sending along this in follow-up. It's also available in the chat. So please take a look and feel free to click there. And then one other ask before we all let you go, we do have a very brief survey that we're conducting in partnership with Qventus. Super straightforward. It'd take you less than 5 minutes to complete. So if you don't mind, that is being shared in the chat today as well. And we'll be compiling this data and putting it into a new report that will be made available to all participants. So really appreciate you taking the time to do that. And then lastly, just of course, a huge thank you to our panelists today for putting on this event with us from HonorHealth and Qventus. We hope you all enjoyed the session, and please, like I said, look out for the follow-up and don't hesitate to reach out with any questions.